everyone. Thank you so much for joining. My name is Dr. Carrie Hersh. I am an MS neurologist at the Cleveland Clinic Lou Ruvo Center for Brain Health in Las Vegas, Nevada. I am the director of the Multiple Sclerosis Health and Wellness Program, and I am pleased to be able to present this program today that's entitled Engaging the Patient in Disease-Modifying Treatment Decisions. First, I would like to thank our sponsors, the France Foundation and the Consortium of MS Centers, for this program that you are about to hear. So without further ado, let's get into it. So it's always really nice to be able to have these programs with the case scenario embedded because I think that it nicely reflects real-world practice. So let's go ahead and do that. So we're going to start with Adele. Adele is a 37-year-old woman with a new diagnosis of relapsing remitting multiple sclerosis. She's married, has 2 young children under 5 years of age, and she works full-time as a 4th grade teacher. She's read up on disease-modifying therapies and is confused about which one would be right for her. And she's looking for guidance on how to select her first disease-modifying therapy and best approaches for long-term optimal care. So I'm going to present a few questions, and then we'll go ahead and we'll answer some of those questions with the subsequent slides. The first question: how do you begin the conversation about an initial disease-modifying therapy? And the second question: what are some important factors to discuss? And lastly, who makes up the multidisciplinary team to provide long-term comprehensive care? So the multifaceted makeup of the MS neurotherapeutic landscape is growing in complexity in terms of administration, effectiveness, tolerability, and safety profile. And there's been an explosion of new disease-modifying therapies, especially over the past 10 years, with 8 new disease-modifying therapies over the past 3 years alone. And while this plethora of new agents creates more choices for the patient and the care partner, disease-modifying therapy selection can still be daunting and confusing with the vast array of available therapies, which may delay treatment. Therapy selection is therefore a balancing act, weighing between a more favorable safety risk profile of lower effective therapy against the higher potential safety risks of a more highly effective therapy. And as stated before, the complexity of choices may lead to patient uncertainty and confusion, resulting in barriers to treatment initiation and adherence. So for the long-term management of chronic conditions such as MS, physicians are moving away from a model of making treatment decisions for the patient, otherwise known as paternalistic decision-making approach, to more of a shared decision-making model, which warrants a comprehensive review of patient preferences. Shared decision-making models promote better long-term outcomes for patients and are especially important for those with relapsing forms of MS for which multiple reasonable treatment options exist. And there are a variety of key factors that should be considered when deciding on an initial disease-modifying therapy or when switching to an alternative agent. In addition to considering the effectiveness, the tolerability, and the important safety considerations for a particular disease-modifying therapy, other important key considerations include things like access to care, such as cost, or whether the person has access to an infusion facility if an IV disease-modifying therapy is being considered. Lifestyle issues, such as the ability to take off of work if the patient has to go to an infusion facility for an IV medication. Family planning and ability for the patient to adhere to the treatment schedule. All of these factors are crucial components to consider for individualized, personalized care. So evaluating patient preferences is a crucial step in shared decision-making in relapsing forms of MS, and it's one that may significantly affect patients' initial and long-term compliance with disease-modifying therapies, according to a published study in June 2014 in the Journal of Neurological Sciences by Dr. Wilson and colleagues. So they performed a conjoint analysis which looked at the trade-off between risks and benefits for preference-sensitive treatment choices that are important to decision-making regarding disease-modifying therapies. And specific goals of this study were to calculate the relative patient preference for current risk-benefit attributes of hypothetical disease-modifying therapies and to quantify patient willingness to accept certain disease-modifying therapy-associated risks for certain benefits. So between 2012 and 2013, 289 patients with relapsing remitting MS completed a choice-based conjoint analysis survey. The mean age of patients was 42 years of age, which is a common age for patients who are initiating a disease-modifying therapies. 76% were female and 78% were Caucasian. And to model the decision-making process and trade-offs of patients choosing disease-modifying therapies, the investigators based the survey on all possible disease-modifying therapy attributes. And a mixed effects logistic regression allowed the analysis of patient preferences and estimation of maximum acceptable risk trade-offs for various disease-modifying therapy benefits. And the most preferred benefit was symptom improvement, followed by prevention of progression at 10 years, and then by daily oral administration. And the authors noted that the high desire for symptom improvement, which is not satisfied by disease-modifying therapies, may affect the patient's desire to initiate treatment with disease-modifying therapies and remain adherent to it. So additionally, the patient's clear preference for symptom improvement in this survey study acts as a reminder to healthcare providers that focus on a symptomatic management is vitally important in addition for disease-modifying therapy discussions. Multidisciplinary care is a cornerstone for optimal long-term outcomes in patients with complex needs. And as seen in this graphical illustration, at the core of the multidisciplinary care unit is the patient, surrounded by the neurological healthcare team, such as the MS healthcare provider, the MS nurse, the physical, occupational, and speech therapist, and physical medicine and rehabilitation. And then on the outside perimeter are specialists that are outside of the neurology healthcare team who still play key roles in MS management, such as urologists, OBGYN physicians, orthopedists, cardiologists, and of course the primary care physician. So altogether, each contributes a significant role and unique counsel with one primary goal in mind: to provide the optimal long-term care for the MS patient. Further, counseling around disease-modifying therapy selection can also be augmented by other key players of the multidisciplinary care unit besides the MS clinician. So nurses who are well-trained in MS, social workers, and health psychologists can also assist in both the initial and subsequent conversations around disease-modifying therapy initiation and long-term monitoring to enhance adherence to therapy. So let's move on with our initial case. Let's talk about Adele again. So Adele starts interferon beta-1a subcutaneously and initially does well. But at a routine follow-up appointment 6 months later, she reports recent issues with blurriness and balance. During the visit, Adele states that she stopped taking her disease-modifying therapy 3 months ago due to intolerable injection site reactions. Here are some follow-up questions on our first case scenario. So question 1, what are some important factors to discuss regarding initial disease-modifying therapy selection? And the second question, who makes up the multidisciplinary team to provide comprehensive care? Adherence can be a challenge to the patient. There are many reasons why a patient may not adhere to a course of therapy, which includes depression and cognitive impairment, and a perceived lack of efficacy that may stem from a lack of understanding of the appropriate expectations of treatment, such as some patients feel that if they don't feel better, or if there is a lack of noticeable improvement, the patient is failing therapy. Other potential contributions to non-adherence include adverse events and intolerability, inconvenience of dosing, and needle phobia. A study conducted in 2010 actually showed that patients who discontinued treatment tended to do so within the first 12 months of therapy. Further, there was a clear relationship between poor adherence and reduced efficacy, resulting in further poor adherence, creating a negative cycle of poor disease control. Using a commercial health claims database, a study conducted in 2017 demonstrated the consequences of suboptimal adherence in patients with MS. The results, which included over 12,000 patients between the ages of 18 and 65 years and on 9 different disease-modifying therapies, showed that adherence was similar between injectable and oral disease-modifying therapies. Additionally, adherence versus non-adherence reduced the likelihood of relapse by about 40%, hospitalization by about 50%, and emergency room visits by about 40%. Further, adherence versus non-adherence was predicted to decrease the total annual medical care costs by about $6,000 per patient. An important limitation of the study was lack of data on patients who were treated with infusion disease-modifying therapies, so we are unable to generalize these results to this patient population. So let's go to our second case scenario. So we have Brenda, a 45-year-old woman with a recent diagnosis of MS who has been referred to you to discuss disease-modifying therapy options. However, she currently does not want to pursue disease-modifying therapy and is hesitant to even have a conversation about disease-modifying therapies. She has highly active disease. She has 7 enhancing lesions on her brain and 2 enhancing lesions in the spinal cord that places her at high risk for early disease progression. So let's look at some questions. How do you begin the conversation to educate Brenda about MS treatment recommendations and best practices? And even after a comprehensive discussion about the importance of disease-modifying therapy in preventing MS activity and disease progression, Brenda remains hesitant about starting a therapy. What is the best approach to move forward? So an important strategy in counseling the MS patient regarding the importance of early treatment with disease-modifying therapy is education on the long-term consequences of delaying therapy. Dr. Gavin Giovannoni and colleagues clearly demonstrated that relapse frequency and recovery from relapses within the first few years of MS disease onset can contribute to long-term disability. Further, early intervention at the time of diagnosis via disease-modifying therapy initiation clearly showed reduced risk of disability progression compared to later and no treatment. Such graphical illustrations can augment the conversation by clearly displaying what it means if treatment is delayed. Sometimes negotiation tactics and bargaining are needed. If the patient is still hesitant in starting a disease-modifying therapy, despite a comprehensive conversation on its importance, a reasonable approach moving forward may be to repeat MRI 6 months and then meet back together to review the results. With an understanding up front that if there's evidence of more disease activity, a disease-modifying therapy should be started, it can help forge the relationship between the provider, the patient, and the care partner. Establishing mutual trust is an important step in creating a relationship with the patient. Optimizing treatment choices is embedded in 4 key considerations. 1, patient-related factors. That includes their preferences, their risk tolerance, their comorbidities, such as high blood pressure, high cholesterol, smoking history, and reproductive status. 2, disease-related factors that include severity of their disease, their phenotypic MS disease course, whether they're relapsing remitting MS or primary progressive MS. And of course, prognostic signs. What are some signs for this particular patient that may actually contribute to further disease progression at an earlier age? And then there are treatment-related factors. Efficacy, safety, tolerability of the medication. What monitoring is needed long-term and how often do they need to have the monitoring completed? Dosing route and frequency. And of course, system-related factors. So that includes insurance coverage and access to services. So all of these things do need to be considered when educating the patient on possible disease-modifying therapies. So let's end our conversation on a third case scenario. So we have Simon, who is a 56-year-old man with a long-standing history of multiple sclerosis. He recently lost his job as a food server and no longer has medical insurance. With no current steady source of income, he and his wife are struggling to make ends meet. He is afraid he won't be able to afford his DMT anymore, which has stabilized his disease course over the past 5 years. So unfortunately, this is common in routine long-term MS care. And some key considerations for the audience is, as a healthcare provider, how can you support Simon? And what are some available resources? So having access to a social worker can be very helpful in trying to identify available resources for the patients so that they may continue to afford their medication to ensure that they have adequate disease control. And then there are other organizations outside of your center, such as the National MS Society and the MS Association of America, that have plenty of patient assistance programs that are available. So having a conversation with the patient and the care partner and doing a needs assessment will be able to help identify what the patient currently needs in order to maintain proper and good health. So some key takeaways from the program includes the following. Treatment of MS has become increasingly multifaceted, emphasizing the need for a multidisciplinary approach for long-term care. The complexity of DMT choices may lead to patient uncertainty and confusion, resulting in barriers to treatment initiation and adherence. Healthcare providers are moving away from a model of making treatment decisions for the patients to a shared decision-making approach that takes patient preferences into consideration. And lastly, shared decision-making can promote better outcomes and are especially important for patients with relapsing forms of MS because multiple reasonable treatment options exist.